Hi everybody, sorry for my long absence. It's been a couple of years, I believe. Started a family, all your spare time will promptly disappear when that happens. Plus I've moved, I'm now in New Zealand, a small town called Wanganui, 2 hours north of Wellington. The case that I'm presenting today was done, it's one of my last cases that I've completed in South Africa, and it is a case of internal resorption. It's my first case, and I haven't seen a lot of these. Usually we only see external resorption. As you can see from the angled photograph, we almost missed that, but the lesion, it's there and it's still centralized in the root. I was a bit concerned about the distal bone crest, but probing didn't reveal anything out of the ordinary. Probing seems a bit tedious these days with the dawn of the cone beam CT. However, I prefer to routinely probe all my endo cases on the off chance that there is something wrong that isn't picked up on the CT scan. In the end, I did refer this one for a CT scan purely because I was a little bit in doubt as to why that shadow is distal of the 3/6, and I'm glad I did. Left-hand top and bottom images shows the lesion, the resorptive lesion. No perforation, mercifully, but it also shows on the axial view top left where there's a dent in the buccal cortical plate, very likely caused by a traumatic extraction of the 3/7, and then the 3/8 was simply left to drift forward into position. I postulate that the extraction may have triggered the internal resorption, but it's just a theory. Removal of the amalgam, revealing stress fractures. I want to go as far as to say all amalgams have some form of a stress fracture somewhere, and if you don't agree, then may I suggest that you invest in a microscope. These cracks are very common. Obviously there will be exceptions, but in my opinion 99% of amalgams will have a stress fracture somewhere. Even though the stress fractures appear to be superficial at first, the caries, especially on the distal, was quite extensive. And you can imagine that the opening in the crack is probably like a highway for the bacteria to get in. It destroyed a fair bit of the distal wall, so a preoperative composite buildup was indicated. Also worth mentioning, there was no signs and symptoms of pulpitis at all. The referring dentist basically just queried the lesion, and making the decision to initiate the endo wasn't an easy one. I mean, what are we going to do? We don't know the rate at which this lesion is getting bigger. I opted to initiate the endo before the resorptive lesion perforated the root. Obviously, if that happens, it's quite a bit more of a palaver to manage. If you want to scroll back at the screenshot of the cone beam CT, I think you would agree with that. There's definitely fissure caries on the 3/8 as well, or the tilted 3/8. It's always tempting to want to do it. I mean, we've got the anesthetic, we've got the isolation, but it's not wise if you sit with an endo referral practice. However, if you work in a referral practice doing endo on referral basis, you are relying on the referring dentists. The last thing that you want to do is to have them think that you are hijacking their treatments. So the best way to deal with that fissure caries is to inform the patient plus mention it in the report to the referring dentist. Something I didn't mention on the pre-op is the calcification, reactive dentin in the pulp chamber. De-roofing the pulp chamber revealed a firmly attached denticle. I prefer to use ultrasonics to remove them if I have time. If I don't, it's a fast diamond that you have to be very careful with. It's always a nice moment when it comes out, like in this case, in a single piece. The tip of a size 10K file coated in a viscous chelator to stop the blood from clotting. We don't want blood clots forming, obstructing the canal, especially because this seemed to have been a very rich vascular tissue. A little bit of a fiddle to find the canal because of the irregular texture of the lesion, but since the rest of the distal was nice and large, it wasn't too difficult. The electronic apex locator worked very well in spite of all the moisture and the irregular canal shape. After the working lengths, it was the Wave 1 glider and the Wave 1 gold. I used the Wave 1 prime mesial and the Wave 1 large distal just to pinch off the blood supply at the root tip so that it can stop bleeding and I can start seeing what I'm doing. Startex number 2 to open up the orifice a bit further in an attempt to get all the pulpal tissue out of there. It was a very fibrous tissue. It was also, think of it as dentin flakes in there. Not sure why it formed. I would have expected the resorptive lesion to be without any calcified tissue, but this one had some in it. It was very firmly attached to the site with small, almost like tissue tags. It's like multiple little fingers that sort of grown into the dentin surface, and scraping it off seemed to be impossible. I don't often do it, but I think it's justified in this case. I left the canal flooded with sodium hypochlorite, the idea being that the organic matter in this fibrous tissue would be thoroughly dissolved, enabling the easy removal of the resorptive tissue. The mesial canals I filled with calcium hydroxide as usual, and as I said just now, sodium hypochlorite in the distal. I covered it with plumber's tape. You'll see a small little gap in the distal opening, and when I apply pressure to it, I do so very carefully because I don't want the plumbing tape to seal the orifice, and then we apply pressure to it, forcing the sodium hypochlorite through the apex. A little bit of poly-F to seal the access. I love poly-F. The assistant hates it because it's difficult to mix. Apologies for the different orientation. I switched cameras. I was testing the adapter for the cell phone camera, so all the footage up until now was taken with Samsung S8 Plus, I think. The latter half of the video, the one with the purple rubber dam, that is taken through a Sony NEX5. That's actually my preferred way of recording. I was just testing the cell phone adapter. I do think the cell phone would work very well. It's very good for sharing still images, perhaps even a little bit of video footage with colleagues, with patients, but for video projects I think a dedicated digital camera is better. Sodium hypochlorite softened the tissue. It was easier to remove. Still a challenge, but much easier than what it was previously. The combination of ultrasonics and manual debridement. Ultrasonics done with the U file from NSK and manual debridement with the micro debrider from Dentsply Malifer. That's basically a size 30 headroom with an elongated handle, so it handles exactly the same way a normal probe would. And it works well if you want to see what you're doing in the mirror while you are working. After the bulk of the tissue is removed, I switched to the Startex number 2. This one has got a active tip, but it's rounded. I would not recommend StarTex number 3. I think it would damage the already thin dentin walls. The number 2 worked well to get the last of the flaky dentin chips out of there. Lots of irrigation while we did this so that you can keep all the debris in suspension as much as possible. One tip I can give you is to make absolutely sure that every little nook and cranny in there is clean. Those dentine flakes was hiding beneath all the little undercuts that was there. I actually think sandblasting might have worked better to clear the lesion out, but getting the aluminium oxide out afterwards may also prove a bit of a challenge. Ultrasonic activation worked well to get the last of the dentin chips out as well. My favorite irrigation device is the Endodontic. Very safe and it's very effective. You can move massive quantities of any concentration of sodium hypochlorite through the tooth in a very short space of time. I do activate in between the applications so that we have some ultrasonic waves in there as well. Something I've came across was a wireless vertical obturator, but it's one of the cheaper ones, so it's never quite hot enough to burn the GP off. But now we use it to heat the sodium hypochlorite inside the tooth. I think this works better than doing it extraorally. Circulating it through a thin cannula or a needle cools it down again. So if you want to heat your solution, you may try this. I think it works very well. Happy with the cone fit and the tuck back, so we proceeded to the obturation. As you can see from the size of that GP cone, it was the wave one large for the distal canal. And I mentioned just now we got some good tuck back there. Funny the mess you make. You only see that on the video afterwards, like those 2 red GP cones for the mesial canals. I forgot to even take them out. So for obturating the distal, I chose to melt the GP at the bottom of the resorptive lesion. I think this created a much better orifice seal than what it would have if you tried to seal it at the top of the resorptive lesion. The canal was nice and round, and as you can see on the magnified view, it fills the spaces quite nicely. Continuous wave heat application, creating the apical plug. I included some of the mesial footage purely because it's one of my favorite moments to see the GP flow through from buccal to lingual or vice versa. A sign of proper and thorough irrigation. However, the main focus is the distal canal. Keep the layers thin, make sure the hot tip of the flowable GP applicator melts into the previous layer of GP so that the layers can join together nicely. Little by little, this lesion fills out really surprisingly quickly, and a lot of condensation. Something else that you do notice on the video afterwards is when was the last time that the assistant cleaned out the heat shield on the obtura. I apologize for that. I don't see this lesion being well obturated on any different type of technique. Cold lateral, even carrier based would not have filled out all the little nooks and crannies. And coronal 2 or 3 millimeters of the canal are left open for a little bit of retention on the composite core that we did at the end. In the words of Cliff Ruddle, there it is, the thrill of the fill. A little lateral canal apically to the resorptive lesion, it reinforced what I said earlier about sealing the GP off at the bottom of the lesion before we started downpacking it. And also a nicely filled lesion space. Also note the little ramifications between the two mesial canals. Thank you for taking the time. I hope I was able to show you something new, something that you may use in future practice. I'm not sure when I'm going to have my next video available. It all depends on what walks through the door. Moving to Wanganui meant that I had to go back to general dentistry. I have to say I am enjoying it. Doing endo full time is demanding. Having a practice with an emphasis on endo instead of endodontics only is a bit better. The variation helps a lot. Other than that, enjoy your day and thank you again. Thank you for watching.